decade of the 1980s created a lot of questions in American culture. From Who Shot JR to Where's the Beef, Americans were curious about everything from space travel to time travel. But the 1980s also made a lot of statements. Madonna and MTV, Chernobyl and cats, the Tylenol murders and the discovery of the Titanic, Rubik's Cube and the Ropers, Farm Aid and the fitness craze. It was a time for fear, a time for the fall. Oh, and it was also time to make the donuts. In healthcare, the World Health Association certified that smallpox had been eradicated, and the use of new technology accelerated, including personal computers and telemedicine. The AIDS epidemic began when the first cases of HIV were reported to the CDC by doctors in San Francisco and New York City. Since there was no known cause or prevention at the time, public fears about AIDS grew quickly. Those fears were echoed in hospital workers. Hospitals began developing treatment protocols for caring for AIDS patients while ensuring the safety of the staff and other patients. While America was infatuated with both Reagan's Star Wars and Lucas's, and the public was taking a step back from those who were ill, Marguerite Jackson, Julie Gerberding, and Barbara Sewell stepped up. In the mid-1980s, Marguerite Jackson and Pat Lynch realized that hepatitis B was being transmitted by the undiagnosed patient, and that a diagnosis-dependent isolation system did not protect healthcare workers from bloodborne organisms. This led to a new system of isolation called body substance isolation, as an alternative to the diagnosis-driven isolation system that was in place. The use of gloves was implemented whenever a healthcare worker had potential contact with blood or other body substances. Marguerite is currently retired from the University of California, San Diego Health System. In the 1980s, Barbara Sewell began practicing and teaching infection prevention and control and healthcare epidemiology in the U.S. and throughout the world, consulting with health systems, individual organizations, and ministries of health. Barbara published extensively in the area of infection prevention and served as the editor-in-chief of the APIC curriculum, which would later become the APIC text. She worked in acute care organizations in a variety of capacities and served as Director of Infection Control and Epidemiology for 25 years. Barbara was APIC president in 2003 and continues to be a leader in the infection prevention effort as practice leader of infection prevention and control services for Joint Commission Resources and Joint Commission International. The AIDS epidemic in the early 1980s placed Julie Gerberding on the front lines of HIV care at the University of California at San Francisco. Dr. Gerberding saw firsthand how this frightening new disease made it difficult for some healthcare workers to care for patients. That motivated her pioneering research in occupational infections, which defined the risk of HIV transmission through needle sticks, the scientific basis for double gloving, and the value of post-exposure antiviral prophylactics. She established the UCSF Prevention Epicenter to integrate research, teaching, and lab research in healthcare-associated infections, and became the SFGH healthcare epidemiologist before she moved to head the hospital infections program at the CDC. Dr. Gerberding continues to make a profound impact on infection prevention as president of Merck Vaccines. In the 30 years between Dynasty and Duck Dynasty, a lot has changed in culture and infection prevention. Cell phones and bangs got smaller, while TVs and hard drive capacities got bigger. The Dukes of Hazzard went from the good old boys to just the old boys, but Julie Gerberding, Barbara Sewell, and Marguerite Jackson made lasting impacts as difference makers who brought new meaning to the title, The A-Team.
Julie, I wanted to ask you, from the knowledge here, we know that your clinical training actually started or was in the middle of the beginning of the AIDS epidemic. How did that influence your decision to move into infectious disease? And I'm wondering if you could share a little bit about that story.
You know, it's really hard to go back and think of what it was like when we didn't know what it was. All of my patients were dying. They had pneumocystis, they had cryptococcal meningitis, they had lymphoma, and they were dying, and we didn't know it was an infectious disease. So in the very beginning of HIV, I was an intern, and we were up all night with these deadly viruses around us and didn't even realize that we were potentially at risk ourselves. It was also a very sad time because as people caught on to the fact that this was an infection, they became very frightened, and many stopped providing care. It wasn't just our patients, it was our hairdressers, our neighbors, our faculty. Everybody in San Francisco was affected by AIDS, so you really couldn't train there and not step up And I think it was that process of just recognizing that it is what it is, and we had to roll up our sleeves and figure out how we were going to cope with it, that really made me feel like I needed to do something. And I wasn't going to be a lab scientist, and I wasn't going to be the person to discover the vaccine, but there was something that I could do to contribute to the solution. And I realized when I got hepatitis B on the job, and the CDC had just come out with a guideline that said, healthcare workers, don't worry so much about AIDS, it's transmitted like hepatitis B, that there was an occupational issue. And I think it was that personalization of the risk that convinced me that prevention was an area where I wanted to commit my career, and HIV prevention as an occupational infectious disease in the context of a city hospital like San Francisco General that had so many nosocomial infections, that I just became convinced that my contribution would be in the field of infection prevention, and one thing led to another, and here I am.
And we were actually talking, I practiced as a critical care nurse in the Los Angeles area in the mid-'80s and experienced some of that isolation of patients to where nobody wanted to go into the room. There was so much fear. So thank you for stepping up. And also I wanted to ask, how has that helped in today's kind of addressing epidemics and how we manage that? Where's the translation?
HIV was a tipping point, because prior to HIV, the dogma in the infectious disease world was that infectious diseases were going to be a thing of the past. We had vaccines, we had antibiotics, we were cautioned, don't go into that profession, it's a dead-end street. And then HIV happened, and there was an awakening that infections do emerge. And I think that knowledge now is something that we live with every day, but there was a time when we didn't understand, and that's probably why it took so long to recognize that it was in fact an infectious disease that we were experiencing in the city. So that concept of we're all in this together, infections do emerge, they spread very quickly, and I think a part of that is when something's happening that has a population health impact of the scale that an outbreak has or a pandemic has, as much as we want to be about the science, we don't always have the answers. Mm-hmm. And so we have to be able to learn as we go. And in HIV, we didn't have the science around what was the effective infection control, or we didn't have the science around post-exposure prophylaxis, but we had to use what we did know and adapt that logic and that information as we went forward. I think there's something that's just so true about people in APIC, that yes, we want to be science-based, but when we don't have the science, the next best thing is to use common sense.
Logic.
And so, sometimes
as they say, it's not so common anymore, right?
And I just think it's that practical application of what we do know and some reasonable assumptions about what we don't know that really have been part of the HIV legacy, but really continue today in all of our infection prevention work, and really in all of our public health related to infectious diseases.
That's awesome. Marguerite, I wanted to ask, I was curious how you and Pat Lynch came up with the BSI system, or as it's called, the body substance
body
isolation.
Substance isolation
system.
Yes. In about 1982, Pat and I were working together with several other infection control nurses, as we were called back in those days, with a CDC project called Management Skills. So we were getting to know one another. And an article came out in the American Journal of Epidemiology that showed, it was done in Boston City Hospital by Dean Stagg and Ryan, and it showed that a third of the emergency room nurses at Boston City Hospital had serologic evidence of hepatitis B. Now, a third of ER nurses with hepatitis B markers was a lot.
That's a lot.
Out of a total number of healthcare workers sampled of about 650. And we started thinking about it, and we said, what is it about the emergency room that would make these nurses get hepatitis B? Well, back in those days, nurses didn't wear gloves. Nurses did not wear gloves. There was a psychosocial belief in the nursing school curricula that gloves would make your patients feel bad. And if you wore gloves, you were to hide your hands so that the patient did not feel rejected. Furthermore, in a busy emergency room like Boston City Hospital, who were the first responders when the gunshot wound came in bleeding copiously through the door? It was usually the ER nurses, barehanded. And that made us think that the traditional isolation system that triggered on a diagnosis to get the cart, to put the sign on the door, and to make people behave in a different way wasn't working. The CDC had given people the opportunity in their guidelines if to use the traditional system or to use another system. They were not mandatory to do anything a particular way. So we took that opportunity to use the epidemiologic model of the iceberg, where the diagnosed case is above the waterline and the undiagnosed case is below the waterline, and to develop the concept of body substance isolation. We called it that because it's hard to say blood, urine, stool, sputum, all things wet and wonderful that come out of real and man-made holes. So we coined the term body substance isolation, and the short of which was BSI. We had a lot of people, particularly nurses, really get into it because we said it trigger your behavior, whether you wear gloves, whether you cover your clothing, on the interaction that you're going to have with the patient. What are you going to do for the patient? Are you likely to have a body substance exposure? If yes, protect yourself, and at the same time, you're protecting other patients you take care of subsequently. And hand washing, of course, was a given as part of this. And we developed this system. It was published first in 1984 in the American Journal of Nursing. Not a whole lot of people in infection control read the American Journal of Nursing, so it took a while for it to catch on, but it caught on, and universal precautions came along in 87, 88, specifically targeted at HIV, and the two together melded together over time to become what we now know as standard precautions.
Well, and I've got which is awesome, by the way. Yes. I've got to ask, was something so radically different than what previously people have been doing, how did you and Pat get people to adopt something so different?
Well, Pat and I both had the good fortune of working in academic medical centers. I was at the University of California in San Diego. She was at Harborview Medical Center in Seattle. And we had administrators who were very interested in new things. That's what academic medical centers do. We had infection control committees who were willing to take the risk to make a change because we presented an epidemiologic rationale for why this made sense. And we implemented it at UCSD in about 83, 84. Pat implemented it at Harborview at the same time and actually studied it very systematically and had a landmark study published in Annals of Internal Medicine in 1987. So we went out, we were passionate about this concept. We did workshops, we talked at APIC. Wherever we could get an audience, we told people. Julie knew about it. Julie was a believer. And Julie and I worked together in California many years. And so that's really how it came to be.
Well, and I'm wondering, were those epidemiological principles in the first APIC curriculum that you developed, Barb?
Yes, we had a whole chapter on epidemiology and statistics. The body substance isolation wasn't published yet, so it wasn't in there, but the foundation and the thinking was in there. Yes.
Wow. And so in the development of that, what prompted to actually create that curriculum, and what impact do you think that curriculum had then and now?
You know, in the early 1980s, our profession was still very young. Our science was still quite young and evolving, as it continues today. And we really didn't have a framework for consistent practice. We were very happy, those of us in the field, to have the CDC guidelines, to listen to some of our wonderful forward-thinking physicians and nurses who were starting to break barriers and so forth. But we didn't have something that everyone could follow. So the board of directors of APIC asked the certification committee to provide them with standards that they thought, areas of knowledge and practice that they thought every infection preventionist should be able to master to practice well in the field. So in 1979, the certification committee presented 8 standards to the board, and the board accepted them. So then the board said, okay, now we need content to go with these standards. And they gave that task to the education committee. So I happened to be serving on the education committee at the time, and Sandy Pfaff, some of you may know her, called me up, she was the chair, and she said, "You're going to lead this project." She didn't ask me, she just told me. So I said, okay, and we envisioned this as maybe a 30 or 40 page outline, kind of similar to what the critical care nurses had. We used that as one of our models. Well, as you all know, it morphed and evolved into a 1,000-page, 2-volume production. That was the first curriculum, and then a 3rd volume that came out a little bit later. So we had all these discussions about, should we put this material in? Okay, put it in. No, take it out. We don't need that. We went back and forth all the time. So we did a tremendous amount of editing. And I'll just bet you there's some of you in the audience that have never worked on a typewriter. But I'm here to tell you that 3,000 pages of manuscript were done on the typewriter.
Wow.
And we read every one. So you know the term cut and paste? Yeah, we literally would cut out paragraphs, throw them out, paste something new in, put white out on, recopy it, and so forth. And spell check was here in your eyes. So it was really quite a production. And I want to just acknowledge that we had a team of 10 editors and about 50 contributors. And some are in the audience today. So I want to acknowledge Carol O'Boyle, who was vice chair of the committee, and I know Dottie Thomas is here, who was our pediatric expert, and maybe Gail Bennett, because she usually comes. But we had Dr. George Counts, Dr. Frank Rame, Mary Yarbrough from California, who was our administrator, Pat Hinson, our educator. So we had a wonderful team and great authors. As soon as we released the curriculum, it was used all over the world. And people, our colleagues in the global community, were just hungry for knowledge. And they were so thankful to have this document, which was really intended to be for your personal, professional growth, a daily resource, help you design educational programs, help you prepare for certification. I mean, the board gave us a very tall order. And now, that first document, which we love, Marguerite, by the way, was the associate editor, and her husband was our technical editor. Everybody volunteered thousands of hours of their time, and everybody had full-time jobs. So we met on the weekends, we would fly in, have a meeting, work furiously for 48 hours, fly back home, do our drafts, and so forth. So it was a work of love. Anyway, now it has evolved into our wonderful APIC text, which is in the 3rd edition now, and is continued to be used all over the world by our colleagues. So APIC has done a wonderful thing for the profession by creating these documents.
Well, it sounds like, yes, absolutely. Well, I got some major messages out of here, but one is it takes a village.
Takes a village.
It takes a village to make things happen. And clearly the 70s and 80s served as a real foundation builder to what was to come in the next decade. So I'd like to thank our 1980 difference makers.